Thank you. So, good morning, everyone, including the press who are here, our visitors who are here, and members and officers, and all the people who may be tuned in to YouTube. A big welcome to everybody. We're a couple of minutes late starting this meeting because prior to the meeting, I received an email. And I just want to explain it before we start, and it has delayed the start. So we've received a letter, an email, addressed to all councillors. And I have been asked to read it out publicly, but I consider this inappropriate because at the moment we have the ongoing inquiry from Donna Ockenden, and in no way must we interfere with that inquiry. However, and just to say, it has been sent out to all members, and that's the reason we've had a slight delay. However, I can assure the families who have written this email that the committee will continue to scrutinise maternity services at NUH while the service is considered to require improvement. We would be happy if we can seek permission from the families to share this email with NUH. But until we get permission from the families, we will not share it. All right, so I'm sure you're all looking on your laptops to quickly retrieve it, but that is the reason for a slight delay. So I think we can move forward with that now, and I'd like to seek permission for the minutes of the last meeting. Are they correct? Anybody find any problem with them? No? All right, all in favour, are we? Thank you. Do I have a seconder? I'm sure Vice Chairman, yeah. Apologies for absence.
We've had apologies from Councillor Steve Carr.
Thank you very much. And we have declarations of interest. Who has declarations of interest? Councillor McGrath.
My daughter.
Your
Chair,
daughter.
Who is training to be a midwife.
Right, thank you. Councillor Welsh.
My case is part of the Donna Ockenden review, and I work with the family. I don't know why I can't speak this morning. I'm really sorry. I'm really busy. I'm really tired at the moment. So I'll start again. So I have a lot of involvement with regards to what's going on at NHS with regards to the maternity situation. I work with the families on a regular basis. My own personal case is part of the Donna Ockenden review, and I work with the families and NHS England with regards to, and with NUH with regards to improvements and improving the facilities.
Thank you. I'm sure that's been noted. Thank you. And I have a daughter who works at NUH. And you have...
And my husband's a community staff nurse.
So there we are. We all have a slight involvement one way or the other. Right. So this morning we have a selection of guests from NUH, and I'm going to ask them all to introduce themselves as and when. And we go back to about February time when we discussed the maternity services at NUH. Since then, they've had a CQC visit, and we have had a report, or they've had a report, and they're coming to tell us about it. And we'll see what improvements have been made. So who do I turn to first? Is it Michelle, or is it you, Anthony? Right, okay, you go ahead. The floor's yours.
Okay, good morning, everyone. Nice to see you all. Before I start, if we can be of any assistance with the letter from the families, just let us know. We are working with the families and we want to help in any way. So just make that offer.
Just need permission, Anthony, to send it.
Yeah. Okay, so my job this morning, colleagues, is to introduce the report that you've got in front of you, and then my colleague, Michelle Rhodes, who's the chief nurse for NUH, will go into the detail, and we've got colleagues with us Becky and Gemma, who work in maternity services, who will help us with questions as we go through the report. So in order to set it out, Chair, the report tells the story of two inspections, not just an inspection of maternity services. Our maternity services were inspected on the 25th and 26th of April this year, but our leadership and culture arrangements were also inspected on the 6th and 7th of June this year. That's important because previously NUH had been inadequate for its maternity services on both sites and for its arrangements for leadership and culture, known as the well-led judgment. And the CQC inspected us for both maternity and well-led, and they rolled it all into one report. But it is important because the well-led judgment is as impactful on the overall arrangements at NUH as the maternity services judgments. So for maternity, the hospitals have gone from inadequate to requires improvement, and for leadership and culture, the so-called well-led judgment, we've gone from inadequate to requires improvement. What that means at a high level in the organisation is that we are likely to, we are in a conversation with NHS England about the current levels of intervention which are applied to NUH, and it is likely that those levels of intervention will be reviewed later this year. It's possible that we will be under less scrutiny and a lower level of intervention, but I can't confirm that today because that process is underway. It's also likely that the notices of improvement that were applied to NUH as a result of previous inspections either have been or will be either removed, or the monitoring requirements will be changed because our overall ratings have improved for maternity and well-led. But again, that is part of a process that's ongoing with NHS England. For now, what we're engaged in is making sure that we respond to the actions and the findings of the CQC inspectors when they came to inspect maternity and our leadership arrangements in April and June. And what Michelle will tell you about is the detail of what they found and how we're responding to that, regardless of any process that will be applied by NHS England over the coming months. So with that said, I'd like to hand over to Michelle, please.
Thank you very much. Thank you. Nice to see you, Councillor. Can I also say that Sharon Wallace, our Director of Midwifery, would have been here today, but she's had some surgery, so she's off at the moment. So, but she wanted to send her apologies. So Anthony's already done the front part of the paper, but if I just whiz through it, then it'll make sense hopefully to everybody, and then happy to answer any questions. So the CQC came and did a review of both hospital sites for our maternity services on the 25th and 26th of April. They then came back and did the well-led inspection on the 6th and 7th of June. It's important to note that for the maternity services reviews, they were unannounced, so we didn't know that they were coming to either site. They gave me a call. They gave me a call at 8 o'clock in the morning to say that they were on their way into site. So they're both unannounced. The well-led inspection, we were aware that they were coming because they had a lot of information requests beforehand. So the results were then published on the 13th of September, and as Anthony's already spoken about, both our maternity services at Queen's and City have increased their rating to requires improvement, and for well-led we also increased our rating. I think it's important to say at this point that although we celebrate the improvements that have been made for maternity and for well-led, we don't celebrate that where requires improvement, because that's not where we want to be. So we want to be good and we want to be outstanding, and that's absolutely what we're aiming for. But we must celebrate the improvements that that we've made across the service and across the organisation. So what this paper shows, as you can see, the overall ratings for the trust remain the same, with us remaining as outstanding for caring, and with across the board requires improvement, overall rating being requires improvement. If we go through the rest of the paper, so when the CQC came, they fed back quite a lot of improvements that they had found. And the first section, which is section 3 of the report, talks about the improvements across both sites. So this pulls them all together. So they saw improved numbers of midwifery and staff. They saw better mandatory training. They found that most staff were positive and were really proud to work at NUH, but they did acknowledge that there was more work to do around that because some staff still feel that they don't have enough staff on the ground. The big thing, and the thing that I think our midwives, obstetricians and staff feel the most proud about, is that women that they've spoken to felt that they were listened to and involved in their care. And the CQC wrote in their report that women gave overwhelmingly positive feedback, and I think that's a real boost, and it's something that our teams should be very proud of. They found that the overall management of serious incidents had advanced, and Becky, our head of midwifery, who sat behind me, has had a lot to do with that. She's got a lot of detailed work that she's been doing, so we'd be happy to talk about that. They found one of the issues that we'd had previously that had a significant improvement was our triage unit. We separated that from day assessment, and that's made a massive difference to women being able to get into the organisation if they need to quickly. And currently, and we have sustained over 95% of women being able to access that service within 15 minutes, which isn't a national target, and we do fare better than lots of organisations across the country for that. The CTG monitoring, which was a previous area of concern, they also found to be significantly improved, and staff were following and promoted best practice in this. And then they saw that the senior leadership team demonstrated passion to improve the services and work with the teams and the trust to make sure the staff could do what they needed to do. They did, however, so what that did for the City Hospital, as you can see, is it improved the overall ratings of the City Hospital to good. So the City Hospital was rated as inadequate, as requires improvement, and now is good, whereas the QMC remains as requires improvement. And the reason for that is because ED and the urgent care pathway sits at QMC, and that's not yet being reassessed. So that pathway remains at requires improvement, which keeps QMC overall at requires improvement. But as it says here, the city got good, which is fantastic for that hospital. So we did find things that we hadn't got right though, and the 3 of them are pointed out here. One about the storage of breast milk, one about the storage and administration of medicines, and both of those I can confirm were actioned straight away when they were raised to us. And then they felt that we had more to do about risk and governance, and I would absolutely agree with that. We're on a journey, we've come a long way, but there's still a long way to go. For QMC, they also found the same issues with breast milk and medication, and again we actioned that straight away. They found also a number of other issues. One, we used disposable curtains, and one set of disposable curtains didn't have the correct date for when they should be changed stamped on the curtain, so they picked that up, and quite rightly we sorted that out at the time. A bigger issue for us was our call bell systems on B26, and that's been something that has been ongoing for some time with us, but I can confirm that we now have a fix in place for that. So that has been remedied. They found at Queen's as well that we weren't always doing risk assessment to keep women and their babies safe from potential abuse, and that was a particular issue that they found, one issue around that at QMC, and then again more work to do on governance. So do you want me to carry on through the well-led part, Councillor, as well? Yeah, okay. So for the second part, so for maternity, overall, a step up, but more to do. They found lots of positives, but still stuff that we haven't got right. For the well-led parts of the inspection, as I said, this was an announced inspection. We knew they were coming. They came onto site for 2 days. They've interviewed all the executives and many members of the trust board, as well as had focus groups of staff from around the organisation. So they spoke to the divisional leads, they spoke to pharmacists, they spoke to student nurses, junior doctors, they spoke to a wide range of people from across the organisation, and they collected lots and lots of data. They set up email email lines where our staff could email comments and things in. So it was very wide ranging. Overall, they found many positive developments. You could see from here that they found that strengthened leadership and capacity and capability at board level. There was greater collective decision making and shared responsibility and understanding of where we were going and what we needed to do, and that the board took actions where they were required to do that. They liked the People First plan, thought it was a credible vision and strategy. They did say, though, that they'd want to follow up to make sure we were delivering what we said in the strategy and that it wasn't just going to gather dust on a shelf, which, of course, is something that we'd be really clear that we don't want to happen either. They found that we got an improving culture of high quality care, with the majority of staff engaged, stating that they felt supported, they felt valued and respected, and we've done quite a lot of work on that over the last year and 18 months. So we were pleased to see that staff felt those changes. Those changes were better. They did also, though, pick up from some staff that we still have more to do, and there are some certain areas of the organisation where there are more challenges that we need to address. They saw and noted all the work that we've done around governance and oversight in the organisation, and when they come back, they'll note that, because they noted that it was very new and they wanted to see that it would be embedded across the trust. They talked about quality and performance. They visited our quality committee, they visited our trust board and observed that, and saw differences in the way that our information was presented and the flow across the organisation of patients, although that was still a concern and is a concern for us still now. And then they saw that we had got much better relationships with public, with staff and our external partners. Obviously, again, more to do, but actually significant improvements in that. There was one must be done, which was the trust-wide must be done, and that was with regard to our consistent compliance and the duty of candour policy. As the committee will be aware, that's a statutory duty of candour that was implemented in 2014, and we haven't got that consistently accurate across all of the organisation, although we're very good at saying sorry to people if something goes wrong. We're not so good at following that up with a letter and collecting that information and an audit trail to say that we've done that. So there's more work that we need to do about that. And then the should do action was really about risk, and we expected that. They talked to us about it at the time, that our risk management system was very new in place. We've done a lot of work around that, so they recognised there was still more to do. The last two sections are really our future areas of focus and our next steps. You can see, I won't go through them line by line, but there are 6 in our maternity improvement areas, and we carry on. We're going into phase 2 of our maternity improvement plan programme now. And you can see what we're focusing on in the coming months. This is really owned now by the Family Health Division and the midwives and obstetricians in the division really own this, taking it forward, which has been brilliant to see. And then on the final page is our what we're concentrating on for our well-led areas, what we've got to do, and these all align to our People First strategy. So I'm happy to take any questions on any of those. Councillor, thank you.
Thank you to both of you. Before I hand over to members of the committee, things will only start to improve if you have sufficient trained staff. What is the retention of the staff these days? Are they leaving? Are they staying? Have you encouraged them? I'm going back 2.5 years. Have you encouraged them in some way to stay with you? Or have you still got an exodus of staff? That's my first question. And the second question, which I'm going back 2.5 years, is how many serious incidents have you had in the last 6 months? And by serious, I mean, obviously there's different categories, but it concerns me if there are still ongoing serious incidents. Can you answer that, or is Anthony going to?
I'll start, Chair, with the staffing issues. at a trust level, and then colleagues will drill down to maternity, and then
Right,
colleagues will
okay.
pick up the serious incident question.
Thank you.
So at a trust level, we've invested £350,000 in our HR service because it was under-resourced, and that has helped us reduce what we call our time to hire, so the time between offering someone a job and getting them on the wards. That's gone from 80 days to 44 days, which is a significant improvement. We've also increased the percentage of our successful first-time recruitment, so getting it right first time, from 54% up to 80%. So it's now 80% of the time that we offer a job to someone and they then arrive. We have reduced our dropout rate, so that's people who drop out of a process before we either appoint them or they take up post, from 27% to 6.5%. Our vacancy rates have gone down to 9.9% from a high of 12.6%. We have reduced turnover from 12.9% to 11.4%, and we have reduced agency spend by £1 million a month, and we no longer have anybody on what we call off framework agency arrangements. In other words, very high cost agency arrangements. That data is at a trust level, and colleagues will now help you understand what we're doing in our maternity improvement programme.
Thank you. I'll start and then Becky can pick up from me if that's okay. Following on from what Anthony said, for maternity specifically, we've employed a matron for recruitment and retention of midwives who's having real success in working with the universities with our newly qualified midwives and those midwives that have been there some time. So we have seen a drop off overall in the last year of our turnover for midwives. For the first 6 months of the year, for the first time in, well, I've been here for 2.5 years now, so for the first time, at least in that point, we were getting more midwives in than we were losing. That is up and down a little bit and has been for the last couple of months. So there's lots of work that we've been doing, including extending our flexible working hours to midwives. We know that a lot of our new midwives that are qualifying now don't want full time, so they tend to want 3 days or 25 hours, because it's a completely different generation than it was when I trained, where you came and you did full time and you stayed forever. Our new midwives and our new nurses don't have that same philosophy. So we're trying to be as flexible as we can with them. We've just invested in additional support to roll out something called self-roster. A maternity are just next to be rolled out. That means that the staff do their own rostering, so they sit down as a team and they work out what shifts they want, when they want to work, and they do that together. And in those areas where we've done that, where I've done that in previous organisations, and what we've seen here at NUH is that reduces sickness rate, it reduces turnover rate and vacancies significantly because staff feel involved and valued. So we're just rolling that out now. We've invested more in our PMAs, which are our professional midwifery advocates. They offer support to newly qualified or to anyone who is involved in an incident. They spend quite a lot of time, so we have more of those in maternity. We have now got Becky in place, who's our head of midwifery, reporting to Sharon for governance, and then we have a second head of midwifery for operations and recruitment, who's on the floor all the time walking the ward, so we're much more visible than we have been before. So there's quite a lot that's happening in maternity and across the rest of the organisation. We've recruited from overseas, so we've taken I think in the last count was about 15 overseas midwives as well. So we're doing quite a lot, but there's always more we can do, Councillor. So we have reduced the vacancy rate in midwifery, but there are still vacancies. So we have still got more to do. Working with the university is really key to us in this, because we keep quite a lot of our student midwives that qualify that live in Nottingham. We keep quite a lot of those, but those that come to train here, they still go back to where they came from. And what we need to do is to work on how we say Nottingham's a great place to be and to live, so that we keep more of those as well.
I guess your results will prove that, won't it?
They will do, yeah.
And how are we with serious incidents?
I'll hand over to Becky for that. Is that all right, Becky? Pass your bit.
No, I haven't been here before, so nice to meet you. So, in terms of serious incidents, I think last time we came, we were currently working through a large number of SI investigations. So just to confirm that since we last came, all of those in that, as it was termed, the backlog of SIs have been closed. They were largely closed by the end of March deadline that was in place, and the two that we were unable to resolve within those timelines closed shortly after. So we're in a much better position. You asked just then specifically about the number of maternity SIs that have been declared in the last 6 months, I believe was your question. Yeah, so in the last 6 months we have declared 9 maternity SIs. We would never expect not to declare those, declare any SIs. It's based on us, sort of reviewing the care that we've provided and identifying opportunities for learning, as well as some of them are based on declarations are based on outcomes. So, for example, those cases that will be automatically reportable to HSIB, for example, there's a set of outcome criteria that we need to report on those. So, we've got 2 cases that are currently open to HSIB investigation, one of those declared within the last 6 months. I'm happy to give you any more detail as needed.
Thank you.
Thank you very much, Madam Chairman, and thank you very much, Mr. May, for coming to answer these questions on your inspection. Thanks for bringing your team with you. I see from the report that the services provided on your inspection highlights a range of areas where significant improvement is still required. Can you tell us when we will see this improvement to good, as you've already had a number of months since your inspection? My second question, you're also saying that significant improvement has been made on how the services are managed. I just wondered what proof you had of that, and how are you measuring the improvement? Can you give this committee more details on that? The next question is, you also say that there's been a reduction in staff reporting bullying, with significant progress in improving the culture. Are you sure the reduction in reporting is not because of fear of retribution, and there has been so much publicity about this issue that people may be reluctant to report it? This is
That's
especially true.
Questions now, Councillor Wilmot. Let them answer them.
Yeah.
Okay.
This is especially true with this prospect of the police investigation starting in 2024. That's three of the questions. I have a number, but I'll let you.
Chairman, it's even more important than the Donna Rockington review that we don't talk about the police investigation. This is a police investigation that is going to take place, and no one should be discussing it, especially not in this arena, and it's highly inappropriate that happened.
It's not a question, that was an observation.
You are failing parents if you bring it up. It's not acceptable.
Okay, Chair, thank you very much, John. Nice to see you. I can certainly answer the first part of your final question. I'm happy to. The first question was about how we get from requires improvement to good. And given that we've got media in the room, and when we published the report, I answered that question by saying I hoped to get from requires improvement to good in 3 years. I ought to be consistent in my answer. And of course, since the inspection, several months have already elapsed. So we're on with our improvement journey. We've submitted our action plan to the CQC because trusts that are requires improvement are still required to submit their action plan. And we're working really hard, both in our maternity services and more broadly with the leadership and culture of the trust, to consolidate the improvements that have been made and make further improvements. Before I give you some examples of those, I would like to take this opportunity to thank the staff at NUH, because although we are not complacent and requires improvement, as Michelle said, is not good enough for NUH, the staff have worked really hard to secure these improvements, particularly in maternity services. In maternity, then, the journey to good rests on our maternity improvement programme. We reported on that last time we came here, and we continue to focus really hard on every aspect of that programme. The programme is governed by a maternity oversight committee that meets every month. It meets this week, I believe, and is chaired by one of our non-executive directors. So a bit like an elected member, a non-executive director holds us to account on the actions set out in the maternity improvement programme. And they're split into a number of themes, many of which feature in the report. Might be staffing, recruitment and retention, might be culture, for example, and we've got a culture event later in this week, which is designed to bring partners into our maternity services to understand what we're doing, particularly to improve our services for women and families from ethnic minority backgrounds. So culture is what we're doing in the service and what we're doing to help make our services more inclusive. And there are other strands to the maternity improvement programme which are about the technical and performance aspects of the clinical pathways and the journeys that women and families take through our services. And I'm sure colleagues could give you some detailed examples of those actions and the improvements that we hope to secure through them. In terms of how we manage improvement, the Trust has an integrated performance framework, and maternity services is part of that, alongside all the other measures that were held to account, whether it's our urgent and emergency pathways or our elective pathways. That integrated performance framework is reported to the Trust Board in public every other month when the Trust Board meets, and inside the Trust there is a comprehensive programme of meetings between the executive of the Trust and the clinical divisions, and they happen once a month. I think they're all due to happen next week. That's where the senior clinicians and the management of the divisions meet with the executive and go through the performance targets in their particular area. All of that, we hope, adds up to a transparent means of holding services to account both inside the Trust and publicly. Moreover, the People First initiative, that's the blueprint that's referred to in the report as being a credible vision for the future of the Trust, is also subject to separate scrutiny, and all of the strategies under People First either have been or will be approved by the board in public, and they will be scrutinised by the board in public on a rolling basis, and there will be a first year annual review of People First in the early part of 2024. You asked about how I could be sure that the management and leadership of the Trust is improving. Well, first of all, and this is not a commentary on colleagues who've worked in the Trust previously, it's just a fact that we either have or are recruiting new board members to the Trust and new executives to the Trust to give us new capacity and skills. We're also looking at how we train and develop our leaders. We've just been through an extensive leadership development programme with our aspiring leaders, because it is true to say that culture in the organisation has been affected by the quality of leadership, which the CQC found, and there is no doubt also that some of our leaders have not had sufficient development and training, and we're on with that now, and we're just about to develop the second phase of that leadership programme. You then talked about bullying and whether what the CQC saw in terms of reduced reporting was somehow an indication that people still feared retribution. There are good signs, both in the CQC report and in our staff survey, that staff feel more able to speak up, particularly when they might be concerned about behaviour. And it is also true to say that staff come to me very regularly with concerns about behaviour, and I think they feel more comfortable in speaking up. At the same time, we support our Freedom to Speak Up Guardians. There are 3 of them, and they have a number of champions in all parts of the Trust to go out and talk to colleagues and encourage them to speak up, particularly if they fear bullying, and especially if that bullying has an element of racism in it. and they are reporting to me that they are getting more people coming to talk to them, not less, which I take as a good sign that people are more comfortable in speaking up. Additionally, we published in March of this year our Charter on Bullying, Harassment, Racism and Discrimination, and we have a whole programme of work supporting that charter and encouraging people to speak up. And we hold trust-wide open meetings with the executive where people can come along and talk about the things that are happening in the trust, good and bad. And we are constantly out and about in the trust, much more visible than previously as a group of senior colleagues, encouraging people to tell us what's going on in their workplace. And by my estimation, it is improving the culture, but there is a lot more to do. Thank you, Chair.
Thank you, Chair. I have two questions. Should I pose them both now, Chair, or one at a time? As you wish. Okay, the first one is just in regard to pharmacy services. So on page 32, the third paragraph down, that's the paragraph I'm referring to. So I just would like to know what actions have been taken by the leadership to address pharmacy services staffing shortage that have been identified, and what have been the impact of these. Just on a personal note, I've recently had a planned procedure at the QMC, and due to the issues in pharmacy, I actually had to stay overnight because the medicines that I required to go home with from pharmacy hadn't come up. Despite a lengthy wait. So I then in turn had to take up a bed on the ward that I needed to have taken up if the medicines had reached me in a timely fashion. And I'm sure I'm not the only person that this has happened to. Thank you.
I'll start with that one. Michelle might want to chip in as well. So first of all, I'm sorry you had a long wait for your medicines. Regrettably, it's not uncommon. Our pharmacy services are under enormous pressure. The pressure from the trust is considerable, and of course that reflects in pharmacy because most people who come through pathways in the trust will require an intervention from pharmacy. We are working really hard with the pharmacy leadership. The service is extremely well led, even though it's under pressure, and I've asked the head of the pharmacy service, Judith, to come up with a pharmacy development plan that we can scrutinise at what we call our Trust Leadership Board, which is the executive level scrutiny for the Trust. And in turn, that means we'll be able to help Judith get the right resources and capacity into the service, because as well as struggling with staffing, and pharmacy services across the NHS struggle with recruitment and retention of pharmacists, we'll also be able to help Judith with the assets that she needs, whether that's better quality accommodation, because we make and store and package and distribute lots of drugs from NUH, or it's the working conditions for colleagues so that they're modern and more up to date, because at the moment there's an awful lot we need to improve around either recruitment and retention or the working conditions of our staff. It's been elevated to a much higher priority in the Trust than previously, following some visits I made to pharmacy services a few months ago, and other executive colleagues have followed those up, and we're working very closely with pharmacy services under the leadership of Judith to come up with an improvement plan. In the meantime, there is of course contingency so that we cover staffing shortages using temporary staff, although it's very difficult to get temporary pharmacy staff as well as it is permanent pharmacy staff. So we are doing our best to make sure that Judith is supported and we speed things up. The single biggest initiative that we've implemented recently, which is making a big difference on the availability of drugs across the Trust, is the electronic prescribing module. That means that our doctors on the wards no longer need to write out handwritten scripts. They can make all of their prescriptions using an electronic module which links into pharmacy services, so they receive their work digitally and then they can dispense the medicines more quickly. Nevertheless, we are still hampered in certain parts of the Trust, either by recruitment and retention or poor accommodation and facilities for pharmacy, and in the case of the City Hospital, by the opening hours of the pharmacy over the weekend. because they're not open all weekend, which can sometimes have an effect on discharge rates. Part of the reason we don't open all weekend at City Hospital is because of the availability of staff. We just can't get enough staff to work the weekends. So there is some good news in this, especially with the introduction of EPMA and the fact that we are now more focused on pharmacy than perhaps we were previously. But I'm afraid sometimes the service can be patchy, notwithstanding the fact that our pharmacists are absolutely excellent, work extremely hard, and very often go the extra mile for patients.
I'm being greedy this session. Also, just on page 31, it says the Trust shared with us the status of the plans to increase productivity and reduce waste by 84.1 million. I'm on a lot of medications, and I often have them delivered by an outside company. I won't name them. And they sometimes bring my medicines, and once they've come over the threshold of my doorstep, and I've then opened these medications, I'm sometimes discovering that they're not the medications I should have. They then say, because they've come into my house, they won't, despite the fact that they're then packaged within the box that I received them in, and they come in bulk, so probably 3 months worth of medicines, which is, hundreds and hundreds of tablets and different nebulizers and things. They won't then take them back because they say they've been in my house. And every time they say it, I struggle to believe that they won't accept them back. It just seems such a waste.
Well, I agree with you. It seems like a waste to me as well. The finer points of how they're dispensed and delivered to you probably bear further examination with Judith and colleagues in the service, and I'm very happy to take that away, especially if you've got a bit more detail. If you drop me an email, then I'll see if we can unpick that and whether or not there is something we could do differently so that medicines don't go to waste. Because you quite rightly mentioned our productivity and efficiency programme, which is extremely ambitious. Like most trusts across the NHS, we're under considerable financial pressure currently. Everything we can do to reduce efficiency and save money, we absolutely want to do. So if you would like to contact me separately, Sinead, I'm very happy to ask Judith to take a look at that to see if there's anything we can do to fix it.
Thank you. I just want to start really by thanking the parents that did write the letters to the counsellors. I do feel that whilst we're not talking about that other thing, the CQC report has come about because of them standing up and making their voices heard, and I think we should always take that into account. And we should also take into account that for far too long they weren't listened to, and they should be listened to. And I know now that Anthony is working with the families, but there was a lot of history and there's a lot of emotion still there, and it is still really important that we as elected members do everything possible to listen to them about what they are saying, because ultimately they've created a group as well where people are coming to them with current experiences as well, which I know are being reported back. I've fed something back to Anthony only recently as well. So yeah, I'd like to thank the families for the letter that they wrote. I know it wouldn't have been an easy thing for them to do either emotionally. So I'd like to start with that. I'd also like to start by saying that the journey that we've gone on, I think we've come a long way in the fact that you're here today and you are willing to have this discussion. When our first meeting with Councillor Saddington as the chair, which was my first meeting as well, that wasn't the case. And that wasn't that long ago. So the journey that we've had, and largely due to the parents, but also notably, I think, to this committee, you coming in at NUH has actually had an impact on how we feel with regards to that communication. So I think that's a good thing. I think it's a really, really good thing. So that's what I wanted to start off by saying. There's a number of things. You're going to have to really excuse me today. I'm feeling quite personally emotional about this today for some reason. I'm usually quite good at handling this. I'm not finding it very easy today, so I'm not as articulate as perhaps, or non-articulate as what I usually am. So I'm going to start with patient outcomes on 6061, which is 6061 of the actual reports. And I wanted to talk about outcomes for women and their babies remained mixed, inconsistent, and did not always meet expectations, such as national standards. Where areas for improvement were identified, staff used results to try and drive improvement in women's outcomes, but it's not where we are at the moment. And so part of my point here, and maybe it's a point rather than a question, is we're quite far away from where we needed to be. Has NUH ever considered doing what Kent has done, where it has taken certain conditions of women, so people at risk of preeclampsia, gestational diabetes, all of those, and actually had an agreement with another hospital for those women? And the reason I ask that is that I understand from the Kent Hospital there's been an element of success regard to that, because what it has done is it has increased their capacity to deal with other patients, and actually has had quite a successful rate. I'd like to know whether that has been considered, and if it hasn't considered, is that something I would like that to be looked into. And I also understand that hospitals across this country are very struggling with capacity, but actually I think there is something there where we learn from something, where something really bad has happened in the past, where actually they're driving improvements and able to starting to take some more of those patients back. My worry is about use of language, about celebrating. I personally think we should be praising the staff that have moved this forward. I don't ever want to hear the word celebrate ever used with regards to maternity services at NUH for a long, long time. You know, the bereaved parents, everything that's happened, there is nothing to celebrate. There isn't. Praise the staff that have worked hard, praise the staff that are, and I personally praise the staff, the people that are working all out to make that change. I'm not at a place where I feel that this is a celebration, and I know that bereaved parents aren't either. So I just wanted to be clear on that. We're not at that stage, and for a number of reasons that I'll continue with. Equipment on page 86 with regards to the electrical. Sorry, I've just got to find it. Oh, James has marked it off for me. Has he? No, he hasn't. 86. There were 12 items of electrical equipment out of 20 we checked, which had expired electrical testing dates. This was raised at the time, and the staff were unaware of who had oversight of these dates and when they were due. Now, I'm hoping, because I've read in another report, that your CTG, you are getting sorted out. It's 3.5 years too late for me that you're sorting it out now, and my child. But this electrical equipment that you're talking about, it's not them CTG machines. Am I saying it right, CTG? Yeah, it's not the CTG machines that we're talking about, that those were 12 items, were they? Yeah, no, they weren't. Okay, so it'd be interesting to know what those 12 items was and why that 12 items out of the 20 weren't being tested. Medical staff on page, oh god, where is it? Page, I think it's 90. The service did not always have enough medical staff with the right qualifications, skills, training and experience to keep women and babies safe from avoidable harm and to provide the right care and treatment. That's a massive concern, isn't it? I mean, it's there in black and white. We keep babies safe from avoidable harm and to provide the right care and treatment. And this is why I'm saying that it's, for me, if a woman is pregnant at the moment, to read that would be a worry. It's a worry for me. It's a worry for the women of Nottinghamshire at the moment. And I think you know what I'm saying. And last, but certainly a couple of things. Sorry. And last, virtually last, but not quite last. Duty of candour. I think this has to be really, really high up there with something that you have to nail as soon as possible, because it cannot go on. Because when we say that things happen, and I understand your childbirth, there are things that are happening that are completely beyond anybody's control. There are. But when you lose a baby, when you have a miscarriage, when a woman is harmed, when somebody dies, whatever that is within the hospital, actually, when somebody is harmed or died, to have to fight for answers and not get those answers is one of the cruelest things you could ever do to a human being. It is cruel. It is cruel beyond belief. And what it does is, and you face them, Anthony, I know, and you've seen the faces like I have, you see the pain. It doesn't go. It doesn't go when they walk out the room. It doesn't go when it walks down the stairs. The pain stays forever. I don't know how those parents have continued to fight. I don't. So the duty of candour is really, really important. I was wondering, Anthony, whether at your next board meeting you would consider looking at the duty of candour that was produced 6 years ago by Bishop, whose name I've just gone out of my head. That concerns public tragedy, but there is something in that duty of candour, actually the wording on it, that would actually send a message out to the people of Nottinghamshire and to those bereaved parents that your NUH board, as it stands now, because you've made some changes, as it stands now, is committed to duty of candour and will sign up to that duty. And make that public. Because I think what that also does, Anthony, it gives bereaved parents and families that opportunity to say, but you signed this. So I think it gives you power, because I think it's you sending a message to the people of Nottinghamshire, and I think it gives those that are suffering some power as well. You will know from my personal beliefs, I believe that this should be a Hillsborough law, and there should be something bigger than that. But I think as a hospital, as a trust, you would be sending out a very, very positive message. And last but not least, this is not meant to put a dampener on the things that you have achieved, because as I said, I know that there are people working all out to make those improvements in those maternity departments. And I am personally very grateful for that. My concern is the length of time it's going to make these improvements. And my concern is how many more mothers and how many babies and more babies are going to suffer in that time period. That is my biggest worry, because if we bring it back to victims and we bring it back to families and we bring it back to babies, this is why we're all sat around here. You're sat around here because you've got to make the improvements so that doesn't happen. And we, as elected members, have got to try and ask those questions so we help you to drive those improvements in any way that we can. I'm really concerned when I read this report that the improvements aren't enough to protect families. And in fact, it says it in this report. And I want to know how you're going to accelerate these improvements, because it's not good enough to say that this is going to be in 2026. There's a lot that needs to happen here, which is why I said, is there some discussion with NHS England? Is there some learning from Kent, where actually you lighten the load at maternity in order to be able to drive that change? And can I just say one last thing? I also wonder the stress and impact that you all must be on, particularly you, Michelle, as chief nurse. I know this isn't easy for you, and I can tell by your face this isn't easy for you. This is never anything personal to anybody here. I understand that incredible work is going on and you're trying all out to get there. I want it as much as what you do, Michelle, and I know from your face that you really want it. So I don't want you to ever think that it is anything with regards to that, because it's not. I know that you're working hard with regards to this, but we need that change, and we need to drive it forward, and we need to drive it forward quicker. It needs to happen quicker. And like I say, at this stage, I'm not at a place where I can celebrate the improvements that you've made.
Sorry, if you just use the microphone now.
In fact, I should know, shouldn't I? If I could start by addressing the first and the last points. So I would like to join Councillor Welsh, and I'm sure all colleagues, in paying tribute to the families. There is no doubt that their bravery and their persistence and resilience has made a big difference and is a contributory factor to us improving. And I've placed it on record many times, happy to do it as many times as is necessary to show my appreciation and respect for them, because you're right, it's very painful and emotional for those people, and to continue to hold us to account and work with Donna Ockenden and work with colleagues in this room is indeed an act of bravery, and I respect it very much. We don't feel celebratory either. Hopefully, in the reporting around this, we've been appropriately humble and expressed our views that there's much more to do, and we want to do it quickly, which is why I'm going to come to your final point. When I talk about a 3-year journey to get the trust from requires improvement to good, that's the whole organisation. I sincerely hope that we can get maternity to good more quickly. But it does depend on the CQC's inspection cycle. And I'm not entirely sure when they'll come back. Actually, Michelle in college will know. But like you, we are very hungry for change and improvement. I will just pick up a couple of issues before I hand over to colleagues. We are working with other hospitals. We're buddied with Birmingham Women's and Children's Hospital, and we've got Shrewsbury and Telford Hospital coming to visit us tomorrow. So we're actively working with other hospitals who have either been through this journey or are considered to be good, and trying to pick up things that we can do to improve. Colleagues will know whether we've got arrangements with other local hospitals around pathways and taking patients, but take it from me, if we thought that would improve our services and make them better, we're open to anything. We will definitely have a think about whether we could make a public declaration around duty of candour. I'm talking to the Trust Chairman tomorrow. That will be a decision for Nick, but I'm happy to ask him whether he would consider that and come back to you. The board has been very vocal publicly about its commitment to the families, the review, and to improvement. So I'll have a conversation with Nick to make that suggestion. And now, if I may, Chair, if I could hand over to appropriate colleagues, Michelle will guide me on this. The first question was about mixed outcomes and whether we are consistently meeting national standards. Who would you like to take that?
Challenge.
Hi, I'm Gemma Malin. I'm a consultant obstetrician and one of the clinical directors for maternity. So I think in answer to that question, we do monitor our outcome data regularly through our monthly data, where if there is a national standard, we are benchmarked against the national standard, and we're working with our data analysts to constantly drive improvement in that and ensure that we're seeing a complete picture. So that is something that's then reported and included in our reports to the executive team as well. I'm happy to discuss the medical staff question as well, but I don't know if there's anything else you wanted to add on the standards, Becky.
Yeah, can do. So I think as Gemma's just sort of detailed, we do obviously collect information from a variety of sources. We look at outcome data, which feeds our dashboard, for example, and we also look at patient experience information that comes in through our sort of 4 C's, so where people raise concerns or complaints. We've recently in maternity appointed a matron who is in post specifically for patient engagement and experience, and part of her role is to kind of improve the processes we have around patient experience and make sure that all of our improvement efforts are really driven by the feedback we get from our service users, which has been really positive. We do also undertake a number of what we would term as deep dives, so where we identify areas of concern. We would look thoroughly at the data, but we would also look at how our teams work in those kind of environments to identify opportunities for improvement as well. We've got several of those ongoing at the moment, which then do get reported via various means, so into our Nottinghamshire oversight group and through our quality committees and up to board. I'll hand back over to you then to do your medical staffing.
Can I just add one thing to that? The one thing that we know we've not done as well as outcomes as we should have done is of those families that are from black and ethnic minority backgrounds or from those areas of Nottingham where it's harder to speak up. And I think working with Donna and her team over the last year has really helped us with that. So Donna has a real skill of being out and about, and has helped us to pull together a much more detailed plan than we've had before. We've created a task force to look at ethnic minorities in particular, and the feedback that we get from those families. We've appointed a consultant midwife for health inequalities who's just started, and a matron who is dealing with inclusion. And I think that is a real driver for us going forward, because we know through all the work that's been done nationally that black women who have babies don't do as well as white women, and we've got a lot of work to do on that. So that's been a big part of our work that we're doing on outcomes as well at the moment.
Thank you. So,
Chairman, I think we need to tick off medical staffing and equipment testing, if that's medical staffing first with Gemma.
thank you. So in terms of the medical staffing, we do have some. So our rotas are staffed to a certain level in terms of the number of doctors that we have at each tier. So we run a 3-tier system of junior doctors, and then we have a consultant, and that's on each campus. So we do have some gaps in our senior tier at the moment, and that's not a problem that's unique to NUH. That's a sort of national shortage of doctors at that level. So in order to address that, we absolutely want to, our priority is to keep our women and babies safe, and so in order to make sure that our emergency areas are prioritised, we have a weekly staffing meeting where we look at the rotas ahead to make sure that that we've got those gaps filled by doctors. Quite often we'll pick up additional shifts, or we can move doctors between areas to make sure the clinical areas are, and particularly our labour suites are covered. And we also have our daily multidisciplinary team meeting where we join up with both campuses and the community service to review staffing, and that includes medical staffing, and our junior doctor rota coordinators attend that meeting as well, as do our general managers. So if there are any on the day sickness or anything like that, that will be picked up and addressed through that meeting.
Chairman, on the PAP testing, I'm afraid I don't know the details of the 12 items, Michelle, but I will find out and I will email you. And just finally to thank you for your words about how we're doing, and we don't take it personally. Your job is to scrutinise us. We expect you to do it. I'm happy to come and be scrutinised as many times as is helpful for you and the committee.
Thank you, Anthony and team, for being here today. And you're certainly on a long journey, without a doubt. You've made progress, you've made improvements, changes, etc. In my opinion, there are two key elements to this, and one are the patients. The second key element are the staff. How are you communicating the progress, the improvements, the changes that are being made to the staff?
Thank you very much. Nice to see you. So you're absolutely right. The staff engagement in the improvement programme for maternity is critical to its success, but more widely, staff engagement across the trust is important, because we are the biggest employer in the area and we rely on those people day in, day out, and we employ over 19,000 people, and communicating with them all about everything we do is an ongoing challenge. We have a new director of communications. He's sat at the back of the room. His name is Jack Adlam. Jack has built a new communications team which has a focus on internal communications and external communications. And Jack helps me with our stakeholder management as well, all of which I think was referenced in the report. So credit to him and his colleagues for improving things as far as we have, but there's a great deal more to do. In terms of the wider staff engagement across the Trust, the executive team and the board have a programme of visits. We're out and about, we're very visible. We're trying to get to all parts of the Trust is very difficult, it's very big and it's very complex. So we have a weekly rhythm of communications, call it the Trust briefing, goes out, I think it might go out today actually, which gives the staff all the information they need about what's happening across the organisation. And I do a weekly video updating staff on what I'm doing, what's happening inside the Trust and with our stakeholder management. Equally, we run set piece events. We call them Ask the Executive events, where people can come online, and we have a rota, a list of topics that we debate, from car parking through to maternity services, or more generally the culture of the organisation, and things like our bullying, harassment, racism and discrimination charter. When I joined the Trust, if we were lucky, we might have got 50 or 60 people on those calls. We now regularly get well over 500. So we really are engaging people at a broad level across the organisation. And I keep in regular contact with different cohorts, different professional groups. Just recently, because these are cohorts under enormous pressure because of the amount of people that are coming through the Trust or the ongoing impact of industrial action, I wrote specifically to our consultants, offering them my support and making sure that they've got direct access to me if they need to talk about stuff or raise issues. So I think we have improved our internal communications substantially. In maternity, Michelle and colleagues will be able to tell you about all the things we're doing, because communication is one of the strands of our maternity improvement programme.
Hi, thank you for the question. So for maternity, we have increased the amount of communication we do. The Ask the Exec that Anthony's talking about is done on Teams for maternity. So we do an engagement session where the divisional leadership team, myself, and some other members of the exec team meet with the maternity family health team as a wider team, and we get a lot of people attending that, asking questions. They ask about what's happening with the Ockenden review. They ask about what's happening with the maternity improvement plan, what we're doing. So, and it's really well attended. So the other big thing for me, I think, in maternity is when we first came to this committee, when I first came, the maternity improvement plan was owned corporately, and it wasn't owned by the division. So for all the reasons that were good reasons, it had been pulled together to try and address an issue, and it wasn't addressing the issue because the guys on the ground that were doing all of the work really didn't own it. So the biggest thing for me now is, as Anthony's talked about them, is lots of the conversations that we have with the division now around the maternity improvement plan. They're choosing how to be engaged. They're choosing what the priorities are based on data, based on evidence, based on women's and staff feedback. So there's a huge change in that, and it does feel more positive. So the other thing that Anthony's done with, because we have a maternity safety champion, so I'm a maternity safety champion from an executive perspective, and then one of our non-executive directors, Claire Ermston, is the safety champion for maternity as well from the trust board perspective. And she and I meet regularly with staff. She does walk-arounds all the time and then feeds back into us. And we don't go with her because we just let her get out there and talk to people, and she gets a lot of feedback. We've increased the amount of Freedom Speak Up Guardians in there, and they pass communication backward and forwards to us. So quite a lot happening.
Thank you very much. So I just want to echo what I think everybody else has said, in things that it's good to see there's been an upgrade into required improvement. But I suppose there's still improvement to be made, and therefore there are still questions that need to be asked. And I hope you'll be able to answer my questions in that good faith and in that nature. So the CQC report does acknowledge the change of leadership at the very top, saying there has been an improvement. But to be honest, reading the CQC report, I was actually quite concerned to read about the culture. So I suppose just to provide some context, page 8 to 9, most staff felt positive and proud to work in the organisation. However, we did receive concerns from several staff who felt that whilst improvements were being made, progression was slow, and staff were concerned that Band 7 and 8 staff were not always cooperative or supportive. Page 10, staff did not always feel able to raise concerns without fear of retribution. It acknowledges that the trust were aware of this and were working to address this. However, staff were not aware of this but had not yet seen any positive outcomes or trained to enable improvements. Staff did not always raise concerns or issues with their managers, and in some cases did not feel confident to report through the FTSU process, the Freedom to Speak Up process. Page 11, a small number of staff felt there was work to do to develop these staff in middle management posts. Whistleblowing information received following the well-led inspection suggested a small number of staff did not feel supported, respected and valued by their immediate line managers, and that they had or were experienced bullying harassment. So that's page 11. Now, in maternity in particular, some staff described cultural issues between the ward staff and labour suite staff. Some ward staff felt pressured to work in the labour suite when they did not feel confident or competent, and felt pressured by some labour suite staff. This issue has also been identified during our last inspection. That's page 58. Page 59. Some staff spoke of bullying occurring, either experienced this themselves or having witnessed it. We raised a concern during our inspection of the service and observed an episode of blame towards a staff member involved. Page 58. We spoke with 2 staff members who had been in post for a while and felt their efforts towards career progression had never been successful due to perceived favouritism. That's page 58. So there's a lot of work to be done on culture. So I suppose when I was reading the report from yourselves about what improvements were going to be made, I must confess, when you're looking at the improvement areas, there's obviously the more generalised improvement plans that have been put in place, and I suppose the only mention to bullying in particular was the continue to progress with the freedom to speak up process, and I do welcome, by the way, when you answered Councillor Welsh's question about what you're going to be doing to encourage those to speak up, and you'll be bringing out an outside consultant and actually to help with that progress. But I suppose my concern is I don't think that's going to be enough, especially when you have reports that staff are being placed into situations where they don't feel confident or competent enough to do the job, and if they are feeling pressured by that, then there's a big question to be asked. And although it does recognise the change at the top, it does seem to be blocked in the middle and on the ground. And my worry is if we proceed with almost, I don't want to say just this because obviously I'm not getting full details, but if this is the extent almost of the changes in the culture, we're not going to be seeing any changes that require improvement anytime soon. And obviously culture is so important because it touches upon everything. So, for example, you have the situation with the breast milk and how it wasn't actually being kept in the appropriate storage, and it all adds up, and it's very concerning. And I suppose what I'm asking is you provide assurances that all the concerns being raised by these staff members in the CQC report are not going to be blocked in the middle. To coin a phrase, it's not going to be blocked in the middle, and actually those at the top are going to be listening to those at the bottom and making sure everything's going correct and the culture is going to be addressed. Thank you very much.
Thank you very much. Yeah, so the culture question is at the very heart of our capacity to improve. So it is a really good question. So if I talk a bit about what we're doing at a trust-wide level, then I'll ask colleagues to talk about what we're doing specifically in maternity services. So in the People First report, we identified 3 what I call barriers to success: flow through the hospital, recruitment and retention, and culture. And I think we're making good progress on all fronts. Culture, of course, is a long-term project in an organisation that has been at a low ebb for too long, and where the staff are under a great deal of pressure, largely because of what's coming through the front door and what that means for flow through the hospital, and also because there have been significant recruitment and retention difficulties in trust for many years. But hopefully, by improving flow and recruitment and retention, but also make it a better place to work because people will feel under less pressure, more able to do their jobs more often in a way that they can express themselves, develop their career, and certainly feel more safe. So those are long-term aims. In the short term, we are doing a lot of work around culture, particularly focusing on what you call the middle, what I call the sort of squeezed middle, where colleagues receive a lot of concerns and have to deal with the day-to-day operation of the trust. And then, of course, they get a lot of performance expectations from me and others. We've just been through an expensive program, what we call the Essential Leadership Program, with that cohort. But in truth, it was a bit of a taster, and we now need to develop it into something longer term and more sustainable that particularly deals with some of the issues that you've highlighted, whether that's addressing people's concerns through difficult conversations, because as a line manager, those conversations can be challenging and difficult, whether it's dealing with bullying, harassment, racism, or discrimination. We need to give people the tools and the confidence to do that properly. And not everybody does have the confidence to deal with issues like that, particularly when they're first presented. And we need to encourage staff continually to speak up so that they know that when they speak up, that they will be heard. Some of the things we're doing to ensure that that's the case is, for example, to send our Freedom to Speak Up guardians into the parts of the trust where we get most complaints about behaviour, whether that's our estates and facilities services or maternity. Those colleagues now go to those services rather than expect people to come to them. They're welcomed into the services, and if people want to drop by and talk to them in the course of their day-to-day work, they can, without impugning their right to confidentiality. So we have got a programme of activity to open up the culture of the organisation, and that includes dealing with some of the basics. I know it sounds, perhaps in the context of what you described, banal to say that it is really important that we're clear about car parking arrangements, that the integrated transport system works, that people feel they can get something to eat and drink when they're on shift. Those things do make a difference to culture. They do make people feel better about their place of work, and we're working really hard on those as well, Callum. Now, it might be worth Michelle and colleagues just giving you a bit more detail about what we're doing specifically in maternity.
Hi, I'm just going to pick up specifically the bit about staff being asked to move to areas that they feel unfamiliar with. So I suppose I think it's just important to say that obviously as a qualified midwife and through our mandatory training programme, all midwives should have the skills to work across all areas of the service. I think it's fair to say that although they may have the skills, they don't necessarily have the confidence. And some of that is because we haven't been running a rotational programme across our service for a number of years. And we do have some staff who have worked in particular areas for a long period of time and feel that they've become de-skilled in operating in some of our other perhaps more of our high risk areas, so labour suite for example. So at the moment our head of midwifery for operations and workforce is working on developing a stronger kind of rotation programme and looking at how we upskill our staff and support them to feel confident to work in other areas. It is really important that we do have this flexibility of staff because we need to be able to prioritise based on risk. So depending on what the patient profile looks like across the service, we need to be able to move staff to the area where that support is needed. We are working with the staff to understand how best we do this and what kind of level of additional training and support they might need to feel confident to be able to work in those areas, and that is an ongoing piece of work that's a priority for us.
Sorry, could you put the microphone on, please?
Yes, so very quick follow up. It's on page 10. It says staff did not always raise concerns to the managers. They did not feel confident to report through the FTSU process. So just in terms of Anthony, when you said that people are going to be going into these areas and actually wanted to listen to people, I suppose my question is, why do you feel that people don't feel confident in this process? And is there anything to be done to make people feel confident in the process? Because it's all well and good having people go to them, but if they don't feel
we can to promote their work. If you work in the trust this week, you'll see their pictures come up on your screensaver. And the screensaver talks about the work that they do and promotes their services. So it's a long-term piece of work, but we are doing everything we can to make those colleagues better known across the trust, for them to go to areas of the trust where we have concerns rather than expecting people to come to them, and to support and champion their work at the very highest level. Those colleagues also make regular reports to the trust board, which is held in public, and we've given them new leadership. So our Director of Governance, who's a new appointment to the Trust and focuses on all of our arrangements for governance, also supports the Freedom to Speak Up Guardians and has given them all they need to promote their work and to do it properly, and to keep records so that we can identify trends and areas where we know we've got hotspots. So I appreciate it's not fast enough, but we are very, very focused on supporting their work. They're telling me, I met with them a couple of weeks ago, they're seeing more people come forward now than they've ever seen. So I hope that's proof that what we're doing is encouraging people to speak up. It is also true to say that, like any large organisation, we have a whistleblowing process, so people can speak up through that anonymously and they get the protections of a whistleblower. It's equally the case that some people will just escalate directly to colleagues like me or Michelle, either anonymously or otherwise, and we have a process in place where we always deal with those concerns. So I believe we are driving up confidence levels. If people speak up, then something gets done about it.
Thank you, Chair. Well, can I thank Anthony for coming with the staff from NUH? I think it's clear that there are improvements being made, and that's been recognised in the report. And I think your engagement with this committee is obviously important, because we, as you know only too well, Anthony, we are the interface between the public and yourselves, and they feel that sometimes you're unattainable and inaccessible in that respect. And the situation at NUH has probably hit the headlines for some of the wrong reasons when you consider there are 18,000 people working there, or 19,000 as you just alluded to. Never before have we seen the words requiring improvement as celebrated, as Michelle said, but it's in the right direction, and that's the main thing. And I think it's very interesting to hear the report from Michelle earlier and Rebecca about how you're dealing with maternity services in particularly, because the last time it was on a CQC report, it was about staff not being trained. So that's potentially why we're homing in on that, particularly in light of the broader aspect of what's going on. I'm not going to go into any of that, but what I'm saying is, particularly the word Rebecca used is the risk element, and that's the thing when you've got staff who aren't trained in certain areas, and breast milk, and it's a huge concern if it's not looked after. And the administration and storage of medicines is another one, and using electrical equipment and having it pat tested. So you can hear all these things coming out all the time. I mean, it really is good to hear that you've moved the emphasis of the change to the staff in the middle, as you say, because obviously the parents who are, their real hope and their real aspiration out of everything is that we get real step change from it. And I know you do as well, and I think that's where we're going with it. So the other thing I'd like to home in on is, it says there's concerns about the finances, right, and the deficit could be £84 million over 12 months. Do you feel you're getting enough support from the government, and the report speaks about increasing productivity and waste, which is what Councillor Anderson was alluding to when we talking about pharmacy and dispensing, and it goes right through the whole organisation. We all know that the NHS is a big cash cow, and it's constant battle fighting waste. So I just wonder what your reports were on that, because obviously with everything going on in the broader context with the outside, reports and everything that's going on there, because that's bound to have an impact on your staff's morale, which is why we're picking up on that, and I do think it's good to hear that you are changing it from the bottom up, but education of your staff in the right place is crucial, especially when you consider the risk elements, and that's where I'll leave it. Thank you.
Thank you for those questions. So I'll deal with the money first, if I may. So most large trusts in the NHS are struggling financially this year. It's a matter of public record that the services are under a great deal of strain because of increased need and all the issues we've been discussing today, actually recruitment and retention, high cost of temporary staff, and so on. Nevertheless, at NUH, we have implemented a financial recovery plan. We are working very closely with NHS England and our ICB partners, because the budget for the ICB is accounted for at ICB level these days, so we've formed part of that partnership. Having said that, of course, NUH is the largest share of that budget, so it's very important, and we're working with colleagues in the ICB and colleagues regionally and nationally to do what we can to reduce the deficit. Now, from my experience, since I've been at NHS, I've only had good quality engagement and support from colleagues in the ICB and at the region, and indeed because of the focus on NUH, we get a lot of engagement with national colleagues as well, and they have been empathetic and supportive from day one. Whether they can magic up the kind of money we would need to sort out our budget problems is another matter, and indeed, of course, it's unlikely that they can. So they will be holding us to account on our financial recovery plan, and hopefully over time we will stabilise the money. In the same way that you're used to dealing with the budget here, we've implemented a whole organisation programme of work where we're asking people to come forward with their ideas to save money. And that includes the reduction of waste and the improvement of efficiency. And lots of colleagues have come forward. We've launched an ideas scheme where you can come forward with your ideas. We've had some really good ideas about use of things like these latex gloves. Some trusts across the country have reduced the use of those massively and saved quite a lot of money. We're looking at doing all those small things as well as looking at the overall size and shape of the organisation and what we provide to make sure that we can afford it and do it properly. And in the middle there is that important question about productivity. Can we get more out of our assets? Because the basic equation in the NHS at the moment is more investment but lower productivity. Now there's a whole tale to tell behind that. Thankfully, in NUH over recent months, we've improved our productivity in certain areas, not across the board. If you're waiting today in ED, you wouldn't think we've improved. But in our planned procedures, we have improved our productivity. We're running on average this year at 100%, 107% of activity compared to 2019. So we're taking steps in the right direction. We've also got new facilities to help us improve productivity. We've got new theatres and new wards. The wards are already open, they're called the Jubilee wards on the city campus. The theatre will be open by the end of this calendar year. We've got bids in for more theatres and more wards. They're refurbishments rather than new ones, but they will help a lot with productivity and catching up on our waiting lists. We're also in discussion with ICB and regional colleagues about a community diagnostic centre in Nottingham, which should help people get diagnostic services more quickly and then hopefully get referred to the parts of the NHS which can help them and potentially not come into hospital for those things or their follow-up services if we can provide them in the community. So the approach to money in NUH has taken a step change in the last year, partly because of our financial circumstances, which have got markedly worse. But as you did in the county council, hopefully we can use it to make us more innovative, more creative, more productive and more efficient, and we can also use it to eradicate waste and duplication. But the key thing in our context is that NUH is part of a bigger system. and we are working really closely with colleagues in the ICB and region and nationally to make sure that all the parts of the health and care system in Nottinghamshire work more effectively. Because crucially, in our context, if we can stop people coming to hospital, and then when they're here, we can reduce their length of stay, that automatically makes us financially more sustainable.
Can I just add one bit to that? Thank you very much. From a clinical perspective, we know we've got to do things differently with the money that we've got, and it's a constant conversation with nurses and doctors and midwives about how we can do things differently. But I wanted to give the committee assurance that, and we have got a very robust quality impact and equality impact assessment process in place, so that if we are making changes, we do take it through that route to make sure that we're mitigating everything that we can, so that from purely from the clinical perspective, we are getting sign up from people across the whole organisation to know that we've got to manage this budget more differently. Thank you.
Firstly, I'm losing my voice, so I apologise if you can't hear me. Thank you so much for your honesty. It's appreciated that you're answering our questions and being really honest about everything. On page 3, it says the Trust must ensure there is an effective risk and governance system in place that supports safe quality care for all areas of the service and mitigates risks. I think, Michelle, you said that the risk and governance has gone a long way, but there's so much more to do. Can you just expand on that, and what are you going to do, and when do you think it'll be improved by? Because it seems to me that if you can mitigate the risks, then lots of other things will fall into place.
So if I talk about it for the whole of the organisation, and then Becky, as our expert for maternity, might want to add in fact, Becky, you start with what you've done, because then we can move that back into the overall stuff. Is that all right? Let Becky start then.
Okay, so in regards to maternity specifically, we've been doing a huge amount of work around our governance arrangements, quality, risk and safety. This work is a key part of the maternity improvement programme, as well as our business as usual kind of processes, making sure that they're in place. So one of the first things we've done is move forward with the development of a quality, risk and safety framework for maternity specifically. Now that does feed into the trust framework, but we have specific things that we need to support within maternity that stand alone, so it recognises that. And to be able to do that, we've had to restructure a number of our kind of oversight committees to make sure that we're getting the right information in from right across the service. We've had to strengthen our quality, risk and safety team, so making sure that we've got the right individuals in the right posts so that they can really support particularly our operational staff in making sure that we've got a good understanding of quality, risk and safety right across our service. One of the key areas that we've been looking at specifically is around incident management and recognising that we haven't had the resource that we've needed to ensure that where we do have incidents that we're able to investigate them robustly and fully. So we've recruited into some specialist investigator posts who have experience from outside of healthcare, specifically in investigation. They then work with our clinical leads and clinical colleagues to kind of build that picture within our specific environment. And those two individuals that we've recruited specifically to support maternity are one of them's in post, one of them comes into post next month. That should give us ability to investigate things more contemporaneously and robustly. We're also working with our trust-wide colleagues in looking at PSERF. So this is the new patient incident response framework that the NHS is moving towards, and looking at how we make those transitions. One of the key elements in that is absolutely engagement with families and family liaison. We recognise that we need to strengthen that. We've set up some things within our QRS team already to make sure that we do support families and work with them when things have gone wrong more robustly, but there's further work to do on that as well. I'll hand over to you, Michelle.
Thank you very much for that, Becky. So from the whole organisation's perspective, we're in a similar place. So in fact, we're learning from some of the work that Becky's done in maternity, and taking that out across the organisation, because some of the issues that we have, so Becky's point in relation to working with families, that's not something that is just an issue in maternity. It might be that we've got that in other places, so we're learning from that. But what the CQC last time picked up, not this last visit this year, was that our corporate and clinical governance systems didn't work as one. So now we've got a director of corporate governance in place, Gilbert George, and he's working closely with me and others in the patient safety team to make sure that corporate and clinical governance come together, working much closer with the divisions, in making sure that they understand what governance is, clinical governance. They have their own mechanisms in place, their own committees in place, and in fact have specific staff that look at quality governance, which we didn't have before. So we've been building that up. As Becky said, we've strengthened our oversight committees, made sure that the terms of reference are right, the membership is right, and then the big thing for us is the implementation of PSERF, as Becky's just pointed out, across the whole organisation. So we have a plan in place to do that, and that will be in place on target for April next year, which is when we're supposed to do. So I think Becky's is really good when she describes it, because she's talking about specific maternity. But if you could apply that across the whole organisation, we're nearly as good as that, but not quite. So we're on the way.
I think, yes, Councillor Wilmot, a
Sorry.
quick question.
Yeah, I want to say, can I have the opportunity to continue my question?
No, not really. I think we've aired
So you
this.
deny me the opportunity?
Not really, but I'm watching the time, and I'm sure that people have to go. But Councillor McGrath, did you want to speak?
Yes, I did. Councillor, please. I've been putting my finger up, but obviously,
I'm
whatever.
sorry.
Mine's a question anyway, or a couple of questions, which are basically perhaps towards you, Michelle. One is around shift patterns, which I did ask before, which concerns me, and my daughter might be embarrassed that I am asking about this. Is shift patterns, which concerns me, that we normally do 12 hours, and I'm hoping going forward with your plan, right, which will be more productive, as Anthony pointed out. If you have a shorter working space or day, you then become more productive, right? The other one I'd like to know about is your area of recruitment, because I don't mean area of recruitment. If people are travelling to hospitals further, this enhances why, I'll say it, my daughter has to go to Sheffield, right, for a 12-hour shift, and she won't like me to say that, but it concerns me. And does that affect how you recruit as well? But I know she's training. And the other thing, round your flexible, which I think is a good idea, your flexible shift patterns, within that, would you lose your knowledge and your skill, or have you got things in place? So, when you have your, because we do it at the post office, because I'm a postman, which probably makes me nice and easy to get on with, right? But if you lose your skill and retention, Michelle, do you kind of pick your shifts? Because we have job sharing, right, at the post office, which we brought in a long time ago. But what we do is, say, for example, over the 44 hours, which we're based on now, or 38 and a half, we share your day. So it's job sharing for 25, which actually works when both parties agree. So I just wondered if you thought about that as well. Thank you, Chair.
Thank you very much for that. The thing about job shares, we do have lots of opportunities for job share, so that is allowed in the organisation. If people want to do that, they can job share across full-time hours or part-time hours. The 12-hour shift, and I remember you asking it before as well, is a very interesting one for me, because it isn't mandated that people have to do 12-hour shifts. So as an organisation, we haven't said everybody's got to do a 12-hour shift, because they don't. What we've done is we've put a budget together for the individual ward or department that is established for so if I use a ward, for the number of beds, the dependency and the acuity of their patients, and how the team on that ward choose to roster their staff is entirely up to them. And I think we've got to talk a bit more about that, because I think that our teams still believe that 12 and a half hour shifts are must be done, and they aren't. What we have to do is to live within the budget that we've got, and if they can do that, then there's no reason they can't have a mixture of short and long shifts, because we have a number of staff who still prefer the long shifts. Personally, I wouldn't. I'd want the short shifts. But there are a large number that do, particularly in places like ED and other areas, because it means they get more days off. So I think what we'd have to do is to have more conversations with them about having mixed shifts, and I will take that back from here. The bit about where we recruit from, I don't know why. Did your daughter training in Nottingham, but she has to go to Sheffield?
No, well, she does it. Well, she obviously the uni thing is University of Derby.
Oh, she's
for all the
Derby.
all the placements now, because she couldn't get in at Nottingham.
Right.
I don't know whether it's because of her qualifications.
Right.
She only talks to me when she wants money. So I don't know whether that is why she's got to go to Sheffield Allen, which she's because the people she's met, she's sound with. But that was my question. Surely round our area, is it because of qualification, Michelle, or
it's actually down to the university.
What's available?
Yeah, so the university. So Derby University do have some of their students do come to Nottingham. So why she doesn't come to Nottingham, why she has to go to Sheffield, I'm not quite sure. But we do have Derby University students in Nottingham, and the same as we have Nottingham students in Nottingham and Derby. So it's a university decision. It isn't a decision for the hospital. That one. So it is definitely not something that that we'd not want to have her here, but it's what the university put forward in terms of placements. We have so many placements for students a year, and we can't exceed that. So it may be that we were at a limit, and so they have to go elsewhere.
I will allow you to come back with a very quick question. Bear in mind that if everybody came back to ask more questions, we'd be here for another 2 hours. And I have other visitors waiting, as you well know by your agenda. So one quick question, please.
Right. You say that compliance for mandatory training has increased since March 2022 by 20%. So are you saying that some staff have not had the mandatory training when it is compulsory? And what are the reasons for non-compliance, and what action will you take over non-compliance? Thank you.
Thank you, John. So if I start again from a trust level, then colleagues can drill down into maternity. So compliance with mandatory training is an NHS-wide issue. Compliance in NUH globally has improved, and we have a programme of activity to try and improve it further. Some of the reasons that people cite for not being able to complete their training are not being released from work, so given permission to go and do their training. So we are tackling that, because everyone should go and do their mandatory training. Not being able to access the electronic packages, because quite a lot of the training is done online. We've got another programme of work to make sure that people can access it, or sometimes they do it, upload it, doesn't get recorded. So we've got a whole programme to make sure we're tidying up the processes and systems. The single biggest factor is pressure of work, and people feeling they can't step off the job to do the training. And we're working really hard on that, because we see training as important as any other aspect of what people do in the trust. So we are trying to improve it. We have improved it. Actually, the report does mention that it's really important that people do their training, because it covers things like safeguarding, moving and handling, anti-racism work. It's really important stuff. So we are on with it, John. And gradually the compliance is ticking up, but it's a long-term proposition. Colleagues might want to say what we're doing specifically in maternity.
If all of that, and if I could just add for maternity, a lot of the training in maternity to make sure that safety is as good as it can be is multidisciplinary. So we need to have doctors, midwives, and others doing training together. So what we have done for maternity is we've increased the headroom in the budget. So for normal and nursing establishments, you get a 21% headroom, which means for sickness, for training, there's an extra 21% added into the budget. For midwifery, we've taken that up to 26, so we've invested in that as an organisation so that we'll put more midwives in to be able to release them to do not only the mandatory training that the rest of the organisation does, but also the multidisciplinary training, working alongside doctors, anaesthetists, obstetricians to be able to do that. So we have increased that headroom there, Councillor. Thank you.
Right, members, I think we'll draw these questions to a close now. I think we have this morning looked at this in quite some depth. I'd like to thank you, Anthony, Michelle, and in fact everybody who has come from NUH this morning. And of course we do recognise that both, in fact I can remember, Michelle, our very first meeting, I think it was your first meeting too. So although you are being questioned, I do acknowledge that you weren't here in work when all this problem arose. So I do acknowledge that. And as was explained, I think, by Michelle, it in no way are we criticising you when we do our scrutiny. But I think the bottom line from today's meeting is that women and babies must feel safe, and they must be made to feel safe. And I think this is something that this report does lay open, that they may not feel as safe, and Michelle actually alluded to it, as they ought to do if they were going in hospital today. Clearly, improvements have been made, but I think from the committee it's very clear that we would like to see them faster, as I'm sure you would too. But thinking of the email that we've had this morning very clearly indicates the pain and emotion that is being felt by these parents, this very sad business that happened. Obviously, you have to look at culture, that is questionable, and you have to look at progress of the improvements. What I found quite interesting was some of the points that NUH were actually picked up on by CQC were very basic points that I'm surprised that some of the staff hadn't realised. For instance, the breast milk not being kept at the right temperature. I think we would all make sure that our fire alarms worked in the house, and that's a sort of link in the same way from a point of safety. So I was rather surprised that very basic points have been found. But from this email also, we are now talking about where you are, and it's not for us to talk about where you were, because that is up to the Donna Ockenden report. The only thing I would say is I would like to feel, and I don't feel from this email, that the people who are bereaved, the mothers who are bereaved, are feeling any communication to you at the hospital. I realise you can't do much perhaps because it's in the hands of someone else, but I hope we never forget the feeling that they must have, which I think is unimaginable unless you're actually going through it. And I would somehow hope that there is a link between you, Michelle, even though you weren't here at the time, and the people who are bereaved, so they don't feel lost. Obviously, the Donna Ockenden report is taking time, and I'm sure we would all appreciate that if we were waiting for an answer, it must seem to them absolutely endless. And in that time, I would hope that somewhere somebody's communicating with them just to make sure that they're not feeling out there alone. I know they've got a little group, which Michelle is involved in, but the feeling of loneliness for them must be quite great. So moving on from that, I would ask you to keep us informed of when you have the next CQC report or inspection, and then when you've had it, maybe soon, it maybe not, perhaps you'd come back to us so we can investigate it again. If it's a long time before an inspection, then I'm sure Noel will invite you back. But the inspection report is very useful, and it guides us where you are and saves you coming to explain where you are, basically. But thank you to you all. It's very much appreciated by this committee, I'm sure. And all we can do is wish you well and, speed the process up a little bit if it's possible. I realise, though, that staff who we've had for some time still work in a routine, and it must be very time consuming to try and break that routine. But we do appreciate you coming. We do appreciate your honesty, and as has been alluded to, being able to question you and have answers. So thank you, everybody.
Yeah, I wouldn't mind a 2-minute break if that's okay, but people want to plough on, I don't mind nipping out at the beginning. Can I just say, with regards to being responsible as a county council, it might be useful for our comms department to put out something about the support that's available to people that if they have been harmed in the past. Since we've spoken about it today, it's going to be public again. We've never done it before as a county council. We do speak about it on a regular basis. There are lots of women that have suffered. Is there something that we can do?
Lucas, if we could just.
visitors, officers, apologies for the delay. We've had some questions outside from the press regarding the letter that you've all received, which as yet I still haven't revealed, and the press are dealing with it. I think they thought it was a public meeting where the parents could come in and speak too. So we've had to point out this is a meeting in public, not a public meeting. So there is a difference. So my apologies. Could we have the live stream on, please? Thank you very much. And everybody has meetings at 2. So we'll press on with this. My apologies to Mark and Lucy, who've been sitting here for a long time, and Anthony, if it comes to that. But welcome, and I'm going to move straight on with tomorrow's NUH. Who is here? Who is speaking first? Alex.
Thank you, Councillor Saddington. I think you know most folks, but Mark and Phil, do you just want to say hello in particular?
Hello in particular. My name is Mark Whiteman. I'm Director of Strategy and Reconfiguration at the ICB.
Good afternoon. I'm Phil Britt. I'm the Programme Director at NUH for the tomorrow's NUH programme.
Thank you. So Mark and I are just going to go through a few brief slides, and then of course we're happy to have conversation, discussion as appropriate. So I'll just say 2 quick things before handing over to Mark. So firstly is to stress that this conversation today is about the next step in the process for the Tomorrow's NUH programme. This isn't about the substance of the proposals contained within that programme. There'll be plenty of time over the coming period for us to talk about the substance going forward, but today we're really focused on the process. And the second thing to say is that we're really keen to really work with you as a committee over the next few months, and we're hoping to set this up as sort of a 2-stage conversation over the autumn and winter. So it'd be really good to have an initial discussion today, and then we'd be keen to come back to see you again in either November or December before we get to a position where the ICB board might be making a final decision probably in January. So that's my kind of preliminary bits. I'll hand over to you now, Mark, for a few slides, please, Noel.
Thank you. So a bit of scene setting first. So back in 2019, the government announced their pledge to build 40 new hospitals by 2030. NUH were in the lucky position of being one of those trusts, one of the chosen few. Put that in context, there are 124 acute trusts in the country. So we were in the right third of that number, and it's a very significant scheme and a very significant, therefore, potential benefit for Nottinghamshire and Nottingham City. NUH and the Integrated Care Board have been developing plans for this investment and reconfiguration of Nottingham's hospitals for the last 3 years, and all that work, planning and conversations come together in what we call the pre-consultation business case. And it's the ICB's duty to construct that pre-consultation business case, making sure that the plans for Nottingham's hospitals are deliverable, affordable, and crucially meet the needs of patients, public stakeholders now and in the foreseeable future. And as part of that responsibility, it's also the ICB's duty to make sure that we go out to the public, our partners and stakeholders in formal consultation once the plans are sufficiently well developed and have met the deliverable, affordable parameters. And that's the place we are at now. So that's a bit of the context. Go ahead, next slide, please. So that being the context, I'm just going to walk you through very high level what the plans are when we talk about the investment and reconfiguration in NUH. First off, it's consolidating women's and children's services into a brand new facility at the QMC, creating what will be the first integrated women's and children's hospital in the East Midlands. So that's a very significant component of what we're about. Secondly, it's consolidating most emergency care at QMC in line with Queen's status as a major trauma centre. Third component, and it's kind of the quid pro quo of consolidating emergency care at Queen's, is consolidating most elective services at the City Hospital. And you'll probably know this, but it bears repeating that those trusts that have a separate elective and emergency take have emerged and indeed coped during the pandemic in maintaining their elective lists more easier than their colleagues that where the elective and emergency care are intermingled, because when emergency care is running hot, electives are sometimes having to be cancelled in numbers and at short notice. And then the fourth component of the reconfiguration is creating a two-site centre of excellence for the cancer model of care. Surgery consolidated at City Hospital, and inpatient cancer treatment, so things like haematology and oncology at QMC. So that's a very brief overview of the scheme. The next slide, please, Noel. Now, as you'll no doubt have heard, because it was pretty extensively covered in the media, this headline of 40 new hospitals by 2030 has been nuanced recently. And that's largely as a consequence of in some of these RAC hospitals, RAC being reinforced aerated autoclave concrete, which I am told looks a little bit like an aero bar, and after 20 or 30 years it probably has the structural integrity of an aero bar as well. As a consequence, there are hospitals in the country that are deemed close to failure in some of their operating theatres, and the NHS can't have that. So the government have listened, and some of those hospitals have been brought forward in the new hospitals programme. And being brought forward means that they will get their remedial and reconfiguration work done ahead of others. And as a consequence, Nottingham is one of those hospitals that has been pushed further back in the pipeline for the reconfiguration, which is absolutely appropriate in that context. Nonetheless, the expectation is, although the scheme will now not complete until after 2030, the expectation for the new hospitals programme is that the scheme is ready to go by 2028. So that's the kind of timescale we're on. The last couple of bullet points, and I'll hand back over to Alex. So we are at the stage now, as I say, where both Treasury and New Hospitals Programme have said, okay, this scheme looks good to go, and you're therefore having conversations about going out to consult. At the same time, almost, we had some late-breaking news from our colleagues at the University of Nottingham saying that they were considering vacating the medical school, which sits on the Queen's campus, a very large building on the Queen's campus. And as you would expect, we have therefore gone back to the plans and tried to work out, does that change the clinical configuration? Is there any opportunity in that kind of new late-breaking news that might make us or NUH think differently about the clinical disposition of services? And the headline is, whilst there is undoubtedly an opportunity to use those buildings for a different mix than they are at the moment, if the university decide to indeed move off the Queen's campus, our NUH colleagues don't think that actually there is any kind of clinical benefit to using those buildings, largely because they weren't built to house patients in the first instance. There's a difference between a kind of a teaching room and a ward. I'll say no more on that. Nonetheless, you need to be aware that that's a variable in the plans and something that we'll be having conversations with you and the public about as we go out to consult, if indeed that is the decision of this group. I think I'll leave it there, Alex, if that's all right.
Thank you, Mark. If we could just click on to the next. We've already done it, Noel. Yeah. Thank you. You're quick this time. So just to remind you, we've been talking to the public and talking with you for nearly 3 years about these proposals. Sorry, Noel, just go back one for me. Sorry. Perfect. Thank you. So yeah, we've been talking about these proposals for nearly 3 years now. And we do know that nearly 80% of our population that have spoken to us are in favour of the overall proposals. You can see the sort of detail of that feedback laid out in paragraph 19. We've reported that feedback to this committee several times previously, and that's all been used to kind of build into and feed into the ongoing development of the proposals. And earlier this year, we did some further work, particularly talking to citizens who live in the kind of Bestwood, Baseford, Sherwood, Arnold kind of area, striding the kind of city-county boundary, particularly about the proposals of changes to the city hospital area, which obviously those residents will really consider their local hospital. And we also talk more widely to residents across the whole patch about Ropewalk House in the city centre and how that site might be used going forwards. And you can see the results from that at paragraph 21 in the report. The first paragraph 21, there's two paragraph 21s confusingly. So paragraph 21. So overall, that feedback across those sort of 3 years means we've heard from and acted on the input from nearly 4,000 citizens to date. So next slide. As Mark's already indicated, we've now had confirmed the capital envelope for these proposals, so the money that the NHS is prepared to put into them, and also confirmation from NHS England that they're content for us to proceed to consultation. So we've started to think about what that might look like. You can see I've set out on this slide and in the report some of the principles of how we would conduct that consultation. Particularly worth noting, this will be a really tailored approach by audience. We know at the kind of overall level of the 1.2 million people who live in Nottingham City and Nottinghamshire County, we know quite a lot about them. So we will look to tailor our approach to talk to different communities within that to make sure we hear from a really good representative sample of our population. For instance, that means all of our documents will be in our, translated into the top 5 languages within our patch. And with other kind of accessible materials like easy read or kind of materials for people with lower levels of literacy. And we'll really keep on top of the kind of demographics of people who are responding to our consultation so we can sort of reprioritise our efforts depending on different groups as we move forward. We'll use a real mix of channels, online activities, face-to-face, telephone. We'll be using translators and interpreters as needed. So again, there are no barriers for people to come forward and tell us their thoughts. And we're also going to work outside of our sort of direct area, acknowledging that residents of Derbyshire, Leicestershire, and so on, they also very much access the services of what we consider our hospitals. They're also hospitals for our wider kind of East Midlands area as well. So that just gives you a little flavour about how we might proceed. So next slide, please, Noel. So we're asking you today really about, or telling you about 4 things really. So we're asking today for you to note a couple of things about the proposed clinical model and also around the estates developments that we've seen in recent times. And then critically, we're asking you in principle for your thoughts on proceeding to consultation in the new year. And then really keen to understand what further information you might want later this calendar year. Detailed documents, the consultation document, the consultation plan, the business case. You will, I'm sure, want to see all of those in real detail. And that's why we're keen to sort of start the conversation here today, but look to come back to you at a subsequent meeting, either November or December, to continue this conversation. And then finally, just to say, again, as I said, this was a very process-oriented conversation. Important to note that the final decision for us to proceed to consultation will be taken by the Integrated Care Board, probably in January sometime. But that's why we want to talk to you during the balance of this calendar year, so we can have your thoughts to feed into that decision when we come to that in January. And that's it, Chair. Thank you.
I just want to make sure what I can speak about and what I can't. I can speak about anything that's in this report. Yeah, is that right? Yes. Yeah. Okay. So the first question, I don't know if this is probably to you, Chair, really. Where do recommendations come from with regards to reports? Because there are recommendations on the appendix, which is the report from NHS, which is exactly the same as the recommendations in the report, the council report. So if they advised you on what the recommendations are and we've used them, is that what's happened? Because that's what it looks like what's happened.
No, I haven't had a discussion, no.
Right.
Other than no that they were coming and what their plan was to tell us about tomorrow's NUH.
Okay.
I had nothing to do with the recommendation.
I've just never seen it before where the recommendations are on an appendix from the people that are being scrutinised, and then those same recommendations are on the county council report. I've not seen that before.
No.
I'm just wondering, because it's supposed to be scrutiny, obviously they're not supposed to be telling us what the recommendations are they? That's my question, just to be really open and transparent.
I can confirm that the cover report that I drafted took the proposed recommendations from the documentation that was received. I would say that it's not the first time that's happened, Councillor Welsh, but that there you go. That's certainly where they came from. Yes.
Okay, so my actual question then relates to details with regards to the consultation that you've done with regards to moving first of all, I welcome a women's hospital and a health hospital. I think it's absolutely paramount now that women's health is looked at even more and addressed even more. Things like endometriosis, polycystic ovaries, all of those things, absolutely paramount. And I actually think we've got a really good opportunity while Anthony's here actually to be a driving force on women's health in a women's hospital. But my question is, and I've asked it before, and this is where I want to see a lot of consultation around it. So I've lived in Arnold and Sherwood nearly all my life. And if you live in Arnold or Sherwood, you have your baby in the city hospital, right? That's what families do, unless there's some kind of complication. So my question is, and my request is, that there is a further drive with regards to those families that you've talked about, those areas that are on that outer bit of the Nottingham City Hospital, that we have a real drive with regards to that. And that includes looking at some of those hard to reach communities as well that go just over that border in Forest Fields and places like that. And the other reason that I want to have you to have this drive with regards to it is because one of these things that is coming out of the maternity that we spoke to before is about allowing women to have some choice. And if people have had a bad experience on QMC, they're actually seeing the city hospital as an alternative, even though it's under the same trust. And so it's how you're going to deal with that issue when you're talking about 1,800 families. These are practicalities that I think need to be looked at and addressed very specifically within your consultation. How you do that is up to you. But what I would like to see coming back here is reassurance that those people that live in those outer areas where it's a lot closer to get to the city hospital, they see it as a smaller hospital, and some people like that, and it's about that choice. And that's the other thing that I think is really important for women, that they have that choice. I don't think that's any surprise that I've just said that, because I've said it before. And the other thing that I really do want you to consult on really, really specifically is what is housed in that women's hospital. Because I've said this before with regards to concerns. If you're talking about women's health and you're talking about things, endometriosis, polycystic ovaries, all of those things of women's health that causes issues with regards to fertility, putting that in the same hospital where people are having babies could be problematic. And again, if we're looking at women's mental health and actually their health in general, I really want some consultation with regards to how do we deliver that in a women's hospital where we protect all women and all women's mental health. But on the whole, I'm disappointed with regards to the RAC. I could go into that forever. You'll all know how I feel about that, no doubt, you could guess. But what I'm saying is, I'm very, very supportive of a women's hospital as long as that consultation has taken place that suggests and it comes out that women are happy for it to be on one side. That's where I stand with regards to it. So I'm very supportive of a consultation, and I want you to do it as, like I said, there's some specific things that I do really want you to ask with regards to it. But as I said, a women's hospital that concentrates on women and children is absolutely phenomenal. And if we're the first East Midlands to do it, that would be absolutely brilliant.
Thank you, Councillor Welsh, I'll just say one thing and then I'll hand to Lucy. Just to say that's exactly the sort of conversation we wanted to have here today, so that when we can come back in November and December and set out for you how we will listen really carefully to those residents in that area. And in particular, if it's okay, I'd love to work with you, with your knowledge of those communities, of how we can get that right. We know some stuff, but you'll be able to really guide us about how we do that in real kind of practical sense. So thank you, and I hope that's okay. And Lucy, you wanted to talk about the...
Yes, thank you, Councillor Ostrover. Very helpful. So, in terms of the recommendations for today, we've reached a point where we have developed a set of proposals with expert advice, and I think we've been here today to talk to you from both our own local clinical experts and also through the Regional Clinical Senate. And we've gone all the way through the NHS approvals process, and they have said, yes, we think you should build on the engagement that you've done to date. So just to reiterate that what we've been doing for the last 3 or 4 years is engaging, not formally consulting. And you are free as a local system to go to formal public consultation to develop those further. So that is where we are, and what we're asking you to do really under the summary and recommendations is it's A and D. Approve in principle that you recognise that we've reached that position, and then, as Alex said, to support us and advise us in how we consult and how we create the necessary consultation information. So that is where we are. So as an ICB, one of our duties is not just to make sure that we commission best clinical practice, which is where we use both our local clinical experts and also people like the Regional Clinical Senate, but to make sure that in making changes to deliver the highest quality of care, that we don't adversely impact on access. And I think that's what you're talking about, isn't it? So sometimes the clinical evidence says you have to make a change for clinical reasons, but what we want to hear from you and from your populations is how, in making any changes that we feel are right to make, we ensure that people can equitably access. So I think that's just reiterating what Alex said. The only other thing I was going to say, Councillor Welsh, you probably know that there is a women's health strategy been produced by NHS England earlier this year, and interestingly, we've had already had a lot as an ICB, and a lot of approaches from groups who support aspects of women's health, like the Endometriosis Society. So we won't just be thinking about women's health in the context of the new facilities, but we will be thinking about women's health in that broader context. And I think that would definitely be something that in due course, probably into next year, we would be happy to come back and talk to you about. We've got a clinician who works for the ICB who happens to be an obstetrician and gynaecologist by training who is leading on that. So we'd be very happy to come back to talk to you more broadly about women's health.
Yes, Chair. I just want to talk about the public consultation, how essential it is to get that right, because there are a lot of people that say that they never get to know about anything. So you've got to look into the whole aspect of a public consultation. All the many groups there are, the care groups, the Macmillan service that's done, and the organisational trusts that there are. So many people with good knowledge that need to know about this so that they can put forward their thoughts on it. Also, the timings these meetings, make sure that you don't have them all in the daytime, because there are people at work and they need to be involved in this consultation. And also, don't forget the major church groups as well. A very, very influential bunch of people that need to be able to express their views on this issue. And of course, when you go to these consultations, make sure that any of the information or some of the questions that's put forward, that you get to know about some of the answers to these questions. If you haven't got the there and then, if you haven't got it there and then. So of course, what has already been said, the hard to reach groups and the surgeries. And another thing that I don't frequent pubs very often, but when I go in, they always come to me and say, "We know nothing about it. We know nothing about this, that, the other." I don't know whether how you reach those people. You may have to have meetings at a public house where we've got rooms. You know, make sure that everybody's got the opportunity to put their point of view in. Thank you.
So thank you, Councillor Wilmot. I think that's really helpful. And I mean, I agree with all that. And as someone who does frequent public houses very often, I endorse your approach as well. My principle on these kind of things is we have to go to where people are, not expect them to come to us. So yes, that may mean going to pubs. It will definitely mean going to churches. It will mean going to talk to people in the supermarket on a Saturday morning when they're doing their shopping. That will be the principles. That will be the approach that you'll see set out in our plan when we come to see you again in the balance of this year, and what I expect you will be able to see when we're live on the streets of Hucknall or Arnold or wherever we will be. So thank you.
Chairman, may I just want one more little input? Don't forget the councils in the area, because it's essential that you let them know, because everybody that's here today has been elected by the people to talk about issues on their behalf. So it's essential that you know contact all the councils in whatever form they are.
Can I just ask one question of you, Alex? Is this going out in a form of paper? Well, whether it's going out in a form of paper or online. Can I ask that there's a section for anything else you wish to mention? I think we've learnt that from the New York Hospital Survey, that they want a space to put something they want to put down, and they don't know where to put it. So I've told them to put it on the form. But I think perhaps a space there so they can put what they want is useful.
Thank you. And just thank you for moving forward on this. Obviously, I wish I was younger and have a bright future, but a main thing that does concern me, and probably most councils in here, is whereabouts and the infrastructure around it, because I can get, when I was fitter, on my push bike quicker to City Hospital, right, from Stapleford, and the same to Queen's Mead. I know the tram link's there, but wherever it is, needs to have proper infrastructure around it, and that also includes round where your proposed housing sites are in the area as well, especially if we're going around the city, because we're going out all the time, aren't we? And I'm sure you'll take that into consideration, but thank you.
Yeah. Sorry, the answer is yes, and obviously we're not changing the main sites, but what we do the whole time with any sort of reconfiguration like this is we do things called travel impact assessments. So we go right down to individual postcode level, and we look at where people are accessing treatment, and we work as much as we can through local plan consultations and other things with local authorities to ensure that we are locating our services, not just our hospital services, but our out of hospital services, where people can get to them.
Hello, I'm Sarah Collis, Chair of Healthwatch Nottingham and Nottinghamshire. So hopefully the ICB will approve this to go to public consultation. That's really good news. I've got 3 points. One is looking at how public opinion will be used, because one of the things I think public get very fatigued around is being asked a lot of questions, but we don't often see what has changed as a result. So being able to demonstrate what's come out of the consultation, where that has actually affected change within the plans, I think would be really helpful to improve confidence in any sort of consultation processes that you said we did approach. And so I'm interested in ensuring that happens. Obviously, Healthwatch Nottingham and Nottinghamshire would be more than interested in supporting the development of this consultation. And I think there's something there in terms of ensuring that there is a broad input of diversity organisations that can support the development of the way in which this is consulted, ensuring that those minority communities, and obviously Councillor Welsh has already very eloquently talked about the need to work with those geographies that are specifically affected in terms of their traditional use of services around City Hospital and others, which leads to that integrated transport plan and how the ICB is working across the system to ensure that there is good infrastructure, as you mentioned. And my final question possibly goes to Anthony. Obviously, the news that Mark's given that the medical schools considering moving out of the QMC site. I'm just concerned that has a financial impact on NUH in terms of lost revenue maybe from the school. Obviously, I understand that the buildings might not be suitable for changes, so I appreciate that. But whether or not this impacts on the NUH in general, as it is quite a large income generator, I would assume.
Yeah, very happy to. Then colleagues might follow up on the other aspects of Sarah's questions. So the university own the building and the land, Sarah, so they're not a tenant in that sense. However, the relationship between the hospitals and the University Medical School is intrinsic and actually would be symbolically a big deal. But I understand the university's motivation in that the building itself needs a lot of work. And of course, with the government's workforce plan, we're looking to expand the number of medical student places available. So in the sense that we want to maintain a close partnership and maintain that level of close work with the university on medical school placements, because they're a very important part of what we do and our status as a teaching hospital. I don't think that's at risk at all. In fact, if anything, with the government's workforce plan, the university will want us to take more students. In that sense, it's good for recruitment and retention at NUH, because some of our consultants want to work in NUH because it's a teaching hospital, because of our association with the university, and we have a number of shared clinical academic posts as well. I've got a conversation, I think, on Monday or Tuesday next week with Shearer West, the VC at the University of Nottingham, to talk about all of this stuff. So I hope in the long term we can make this an opportunity rather than a threat. It does leave, of course, the question about what we would do with the building and the site, but that's such a long way down the line. I think for now what we need to understand is the university's intentions, their preferred option, and their decision-making process, and how it links with the government's workforce plan. When we've got a better understanding of that, we'll know, I think, better how we can continue to support the university and medical students, and to make that a relationship which works both for the university and the hospitals.
That's one question, so
Yes, so
the answers to my others.
yeah, just briefly from me, because I'm sure Alex will pick the evaluation question up. So what I would say from my perspective, we, as an ICB, our role is constantly, we hope to be seeking the views of our residents on how services are configured, how they're received, how they're provided, and we do, it is an iterative thing. But I would say, for me, this public consultation, when it proceeds, will be probably one of the biggest ones that I will have done, because it's looking at kind of the future of acute hospital services in Nottingham. So I think it is a real opportunity for us to bring all those knowledges and all that knowledge and insights that we've already got together with, because people won't just want to talk about the hospital services, will they? They'll want to talk about out of hospital services, they want to talk about community services, to bring that all together with the additional insights that we'll get from actually a formal public consultation, and to do exactly what you said, Sarah, evaluate it. Because I think we've got a lot of information and we will get a lot more. This will be an enormous, hopefully, conversation with the public. But actually, the formal evaluation of what we get back is a fundamental part of what we then have to do as an ICB, because we have to then make a decision based on that evaluated feedback. But Alex, I'm sure, can talk about that.
Yeah, I mean, exactly. So I think I heard three things there, Sarah. So one, we need to really demonstrate how the public opinion will be used and demonstrate the impact that it's had. So again, when we come back later on this year, we'll make sure there's kind of a whole section that describes the process and the routes by which we will do that kind of reflecting and thinking, and how we will reflect that back to the people who've taken the time to give us their thoughts. So I think we can definitely do that. You also offered there, Sarah, that Healthwatch will be interested in developing how we reach our really diverse population, and more than happy to take you up on that. Of course, Healthwatch already chair our stakeholder reference group for this programme, so you're already doing a lot of that. But I think as we move forward, we can sort of turbocharge that. And then I think you were kind of sort of building on Councillor McGrath's point around kind of transport and access and infrastructure. So I think that's a point well made, and that will be part of our work as well.
Meetings this afternoon. So you have before you the 4 recommendations that we've been asked to consider. I don't intend to read them out. Can I be assured by you all that you're happy for this consultation to start? Yeah, everybody's happy. And
sorry, Chair.
Yeah, we aren't ready to start, but we do want to continue the conversation with you around how we might conduct the consultation. But as the approval in principle to public consultation is that we're after today, if that's okay.
We'll approve it in principle. And you will return in when? No.
It's in your hands to a certain degree. I think Premier spoke to you yesterday, or maybe today, Noel. Sort of November, December, if we can. Would be,
yes, that's
helpful.
fine. We'll programme that in.
Thank you.
And you can say when you've got something to bring, November or December, and you can liaise with Noel over that. That's fine. So thank you very much to you all. Before I just close the meeting, can I just say that we meet again on the 14th of November, where we are planned to consider the East Midlands Ambulance Service and what has been happening with the engagement exercise at Newark Urgent Treatment Centre. I have been told they may not have the information by that time, and I have asked them that they do have it. Is that correct?
Very Chair, to be absolutely clear, we will be here in November because that's what we agreed. It may be again, though, that our season ticket gets renewed and we'll need to come partly in November and partly in December on that topic.
That's fine.
But we're always happy to be here, so I think that's fine.
So thank you to everybody. I'm sorry the meeting's extended somewhat, but I think we've had a useful meeting. Thank you to all our visitors, including you, Anthony, because I realise how valuable your time is and you're sitting here. And thank you to Lucy, Alex and Mark and Forget. Pardon? I've forgotten because you didn't speak, that's why. Can we have the live stream turned off?